Hello, everyone, and welcome to Community Chats. I'm Sandra Arevalo, Montefiore Nayak Hospital Director of Community Health and Wellness. And today we're going to be talking about asthma, not one of our preferred conditions to talk about because we know that it can be very dangerous for a lot of people who unfortunately suffer from asthma. But today we are here to bring you Matt and Emily, who are going to be our speakers of the day because they have very good tools to help you empower yourself to manage your asthma. So if you have asthma or you have a loved one who suffers with asthma, this webinar will give you some tools so that you can help yourself or those that you love. Without further ado, I'm gonna introduce Matthew Stryker, and maybe you wanna tell us, Matthew, about your company and then introduce Emily.
Sure. Thank you so much, Sandra, again, for the continued partnership with the Montefiore Nyack community and always grateful to reconnect with you all. So by way of introduction, as Sandra shared, my name is Matthew Stryker. Both myself and my counterpart, Emily, we are employees of Amgen. I'm a pharmacist by training, and both Emily and myself are on the medical side of Amgen and excited today to present to you an overview of asthma through our asthma program resources, which is called LUMA. I'll hand it over to Emily to briefly introduce herself, and then I'll go ahead and kick off the beginning part, and Emily and I will narrate back and forth. So, Emily, I'll hand it over to you.
All right, thanks so much, Sandra and Matthew, for the partnership. My name is Emily Rodman, and like Matthew said, I am a pharmacist by background, but I am also an asthma patient. So we're going to be talking a little bit today about asthma as a disease state, as well as give you some tools to help you manage your own asthma, be an advocate for yourself with your healthcare provider, and make you feel a little bit more comfortable about managing your day-to-day symptoms. So I'm going to pull up some slides for us, and I'll pass it back to Matthew to kick us off.
Great. Thank you, Emily. And we definitely want this to be interactive. So while we'll pause periodically at organic stops, if you will, throughout the presentation, please feel free to ask questions however you feel comfortable. If there's anything we can clarify or further review and reinforce, we're more than happy to do so. So first, as Emily shared, I'll be covering some core content as it relates to asthma in terms of what is asthma, and then also recognizing the role that the immune system plays. So to kick it off, as I shared previously, this program is called LUMA. LUMA stands for Learn to Understand and Manage Severe Asthma. And you can see from the objectives on the right, we'll be working toward learning that asthma is a chronic disease of airway inflammation. Thereafter, understanding the role that the immune system plays as a cause of asthma. So I'll be supporting those two. Thereafter, I'll hand it off to Emily to talk about the role that you can play, or perhaps you can play as a caregiver for a loved one with asthma. And then we'll round it out with some additional resources to help support you. So we will go ahead and jump right into it. So I do like to pause on this slide just briefly to help level set us all and kind of define what we mean when we say chronic disease, right? So simply put, when we think of chronic disease, we're thinking of a disease that it's here to stay, it's with us for the long term, 100% manageable, but it's typically manageable either with medications and or trigger avoidance and such. So both medical and non-medical options, which we'll dive into briefly in a little bit. And then lastly, when we talk about airway inflammation, we're simply talking about inflammation, if you will. When you stub a toe, there's that redness, that inflammation, but localized to the airway specifically because that's where this chronic disease is taking place. Next slide. So as we dive into this, I think it's important to recognize and appreciate that asthma is a very common disease. If we don't have it, we would probably know somebody that has it. And across the US, about 25 million people are impacted with asthma. So that's a lot of individuals. Now, if we take a look at that number and dial into the patients with severe asthma, which we'll define shortly, that number is about 5 to 10%. So, still over 1 million individuals are impacted by severe asthma. And then if we take it one step further and talk about patients that have severe asthma, but unfortunately that severe asthma remains uncontrolled, that number is also over 1 million patients. And we'll go ahead and define what we mean when we say severe asthma and then also uncontrolled asthma on this slide. So, in a nutshell, very high level, if you take nothing else away from this slide, severe asthma is defined by the medications that you're taking. Now, more granularly, severe asthma is specifically defined by a type of medication, the inhaled corticosteroid or your inhaler. And if you're on high dose inhaled corticosteroid and another controller medication called a long-acting beta agonist, or sometimes you might hear the medical jargon LABA, L-A-B-A for short. If you're on that regimen, you're considered to have severe asthma, or if your asthma remains uncontrolled despite treatment with those medications, you have severe uncontrolled asthma, which we'll define in a moment. Now, Emily will take a deeper dive into the management piece, but called out here are different classes of medications that perhaps you've seen for asthma management, including our quick-acting rescue medications in the top left around 8 o'clock. I'm sorry, 8 o'clock, around 10 o'clock. And then kind of going counterclockwise, there are long-acting medications like the LABAs, oral steroids, our targeted therapies like biologics, and then finally allergy medications for certain patients. And important to recognize that really despite these different therapies, the higher doses and working to reduce risk, patients with severe asthma may not have their asthma under control and still experience severe attacks or what we call exacerbations in the medical side. And that brings us to the next slide in terms of recognizing and defining uncontrolled asthma. So, simply put, uncontrolled asthma is when you, as a patient or perhaps a loved one, is experiencing those asthma symptoms despite following what we call an asthma action plan, which we'll speak to later on. But think of this as a play-by-play for how to manage your asthma, a blueprint, if you will. So, despite that, in working toward reducing what we call triggers, or those things that we're breathing in that really are just hitting our airway and leading to that inflammation. Again, more to come, but bottom line, uncontrolled asthma is essentially symptoms that a patient is experiencing despite best efforts to minimize those symptoms. So, how do we recognize those symptoms? What are some clues? And one way to do that is to explore the rules of twos. And this is kind of a nice kind of back of the napkin resource, if you will, to reflect on, is my asthma uncontrolled? And going through these relate to both medications as well as symptoms. So in the top left, if you take one class of medication or have it on hand called the SABA or short-acting beta agonist, more than twice per week for symptom relief, that's an indicator of uncontrolled asthma. Additionally, that same medication, the rescue inhaler, albuterol for generic names, is often referred to as one type. If you're refilling that SABA, or as an example, albuterol, more than 2 times per year, that's another call to action that my asthma might be uncontrolled. Now, jumping straight down, oral corticosteroids like prednisone, if you're using these for exacerbations or flare-ups, sometimes we hear more than twice per year, another indicator of uncontrolled asthma. And then finally, rounding out this rule of twos again that we call it, if you're waking up at night more than twice a month because of asthma symptoms specifically, that would also indicate uncontrolled asthma. So answering yes to any one of these questions is a call to action to connect with your healthcare provider as your asthma may not be well controlled. So now we'll take a moment to just kind of visualize what's really going on in the airways as we're talking about airway inflammation. So we'll work on this left to right. And on the left side, what we're looking at is a patient without asthma. And here you can see that the airway is nice and open within the lungs. So that light blue color, it's almost it's a full circle. Air is able to flow freely to and from as we breathe it in and exhale. And I kind of liken this to traffic, right? So here we're thinking about if you're going to work and perhaps you're an early riser, you're getting into work around 6:15, minimal traffic. That's kind of it looks like within your airways, if you will. There's no congestion. Things are able to flow. The air is able to move, and it's a good spot. However, what happens in patients with asthma is that those airways become overreactive to the triggers or irritants like cat dander, allergens, smoke, etc. And that's going to lead to the inflammation, making it harder to breathe. And what you can see compared to the airway on the left is that the passageway, if you will, for the air becomes narrower and constricted, leading to those symptoms that patients often manifest or present with related to asthma. So bringing it back to the traffic analogy, we're getting on the expressway. It's not peak rush hour yet. Maybe it's like 7:15. People are they have their coffee, they're driving, but we're not super congested yet. Um, and then on the far right, that's a representation of a patient with asthma experiencing an asthma attack or an exacerbation where we have further inflammation, mucus, kind of like we have mucus in our nose, same idea down in the airways. And here you get tightening of the airway, things are more narrowed, more symptoms are the patients are presenting with. And this is like peak rush hour, right? So this is when we don't want to be on the roads. We want to try to avoid these scenarios for patients that are living with asthma as much as we can. Next slide. So thinking about that visualization, how might a patient present? Or perhaps if you think back, how did you present or last time you had an asthma attack or when you were first being worked up for asthma? Well, highlighted here are some of the hallmark symptoms of asthma leading as a result of the airway inflammation. I will call out that these are non-specific, so there's other elements that would go into the workup, but these can be part of the puzzle piece that really clues a provider into that, okay, maybe this patient does have asthma. And you can see that these include coughing, chest tightness. So here we'll probably want to rule out and make sure there's no evidence suggestive of a heart attack taking place. The shortness of breath with the gentleman who's kind of tripoding and trying to position himself to get more air in. And then probably the hallmark wheeze that we hear, which could be related to asthma. Maybe it's related to an infection. Lots of different things could cause wheeze. But recognize that individuals with asthma have a unique experience and different symptoms can present in different patients. Or perhaps thinking about the last time you had an asthma attack and the time before that, that can look different as well. So that can vary patient to patient and also within a patient as well. So symptoms are one component. And then as we layer on top of that, what else is a provider thinking about? Or perhaps you recall as you were being worked up or a loved one was being worked up for asthma. And that's highlighted here. So top left, and then we'll kind of go left to right and then down left to right. The medical history becomes very important as we're thinking about perhaps other conditions that can worsen your control of asthma. So we're thinking about things like GERD or heartburn, a history of nasal polyps, atopic dermatitis or eczema, which might be a clue that there might be other specific types of asthma at play. In addition to your medical history, family history will be an important clue if there's a history of asthma or other related conditions. Occupational history, so what do you do for a living? Some of those chemicals perhaps that you might be exposed to in the work setting might be serving as your trigger for asthma. And then lastly, social history as well. Perhaps you don't smoke, but you're around individuals that smoke, and smoking may be your trigger. So all of that goes into that comprehensive workup. Next, we have the physical exam where a provider is going to listen to your lungs. Next, there's lung function testing, which becomes a nice objective way to really quantify or attach numbers to how well your lungs are functioning. And generally, I'm painting with broad brushes here, but generally speaking, when we talk about asthma, it's considered a reversible airway disease. So a provider might establish the baseline and do spirometry testing, which is the gold standard for assessing how well your lungs are functioning. And after that, he or she may repeat that exact same test after giving you a SABA, or again, that quick relief medication to really open up your airways and see if that reversibility is there. So lung function testing is nice to attach numbers to things. We had talked about symptoms. Blood testing can be informative as we think about perhaps what type of asthma you have. So, I think a lot of people think about allergic asthma, but there are other flavors of asthma that don't get as much prime time. So, eosinophilic asthma, which is just another cell type in your body that plays a key role, that could be a driver of asthma. But the blood testing will help inform what type of asthma you have and also may guide future treatment as well. And then lastly, FeNO is a non-invasive assessment to gauge the level of inflammation taking place within your lungs. And I know Emily and I can both attest to this because we both recently did some FeNO testing at a meeting we were at. And can be a little bit challenging to hit this. There's a sweet spot as you're trying to exhale, but I'm diverging right now, but just had that recent experience as far as the FeNO testing. But nice because it is a non-invasive test, again, to assess airway inflammation. So let me just take a pause here to see if there are any questions so far on, how common asthma is to some of the drivers of disease. Again, more to come on the immune system and the management of asthma medically and non-medically, but any questions on some of the content that we've covered thus far?
No questions so far, Matt.
All right. So next, we'll just briefly touch on the role that the immune system plays as it relates to a cause for asthma. So in patients with asthma, irritants, triggers, can use those words interchangeably. Those are going to be really responsible for turning on and activating the immune system, leading to that inflammation that we had talked about. So leading to that highway congestion, right, with more and more cars, if you will, and that narrowing of the airway. So I think most of us recognize that the immune system is very important. It's kind of our internal army to fight bacteria, viruses, and other foreign invaders. And patients without asthma tend to have a typical response, if you will, to the different triggers. So the body will rev up production of different immune system fighters, recognizing the foreign invaders, and then come back to baseline as those foreign invaders are cleared. But what can happen in patients with asthma is the immune system might over respond to something that it should not be responding to. Sorry, actually, I blended those two there. Respond to something that it too much to something, respond to something that it should not be responding to, or perhaps have an unusual response as well. And again, these responses that we're talking about will lead to inflammation, which leads to the symptoms ultimately. So I've thrown around the word triggers and irritants and kind of peppered in a couple during the talk. But what are some examples? I think most of us will think or recall allergens, so cat dander, ragweed, which seem to be pretty bad this season for me as far as outdoor allergens go. But recognize there are other ones that may not be front of mind. Of course, bacteria and viruses are another common one, but things like emotions can play a role and serve as a trigger. exercised, just with changes that are taking place within the airway, that can serve as a trigger. And there's a specific subtype of asthma called exercise-induced bronchoconstriction. All that to say, it's just kind of its own unique flavor of asthma, still has the tightening. And then probably front of mind, or it's getting more front of mind, are the weather and the climate. So thinking about the wildfires here in the Northeast that, aren't taking place locally here, fortunately, but with the winds bringing them down from Canada over the past couple of years, this has kind of become our new norm, right? Thinking up back 10, 15 years, wildfires really weren't a thing on the eastern side, and here we're navigating that more and more frequently. So just being mindful of the weather, and we'll talk about some ways to empower and identify weather-related elements that can guide trigger management. So this slide's a build slide here, but kind of really works nicely to layer together all the different elements that we had just talked about. So we have a patient on the left with a healthy airway. There's no inflammation taking place, and the air is able to flow freely in and out with really minimal to no obstruction. But then what happens is we're breathing in. I'm a patient with asthma and it's wildfire season. And as a result, that smoke is going to hit my airway or surface called the epithelium. So that's probably the most scientific that we'll get today. But the epithelium is essentially it's a barrier, right? Serving as a barrier and then an orchestrator for multiple different effects downstream that we'll talk about. But from there, that barrier says like, hey, I just smoke is here. It really should not be here. Let's turn on the immune system. So different immune cells become activated, and depending on what the trigger is, that'll lead to different immune cell activation. And then from there, we see the narrowing of the airways and that traffic starting to build up, right? That congestion, if you will, obstruction. And then as a result of that narrowing, patients can experience symptoms. They may be mild, or perhaps they may be more severe, leading to an asthma attack or hospitalization, even. So, soup to nuts, kind of what is taking place both within our lungs and then ultimately outwardly as a patient. What are we experiencing? And this just illustrates some of the information we had talked about, kind of just in a more contextualized manner. So triggers turn on the immune cells, kind of like a lock and key. Different immune cells lead to different types of immune responses. Ultimately, that may require different treatment options. And as we had talked about previously, certain blood tests can help assess the type and the level of immune response, but working with your provider to review the results can really help determine potential treatment options for you.
All
And with
right. Thanks so much, Matthew.
yeah, I'll hand it off to Emily.
Perfect. So I know this information can feel a little overwhelming sometimes. It's a lot of science, it's a lot of things to keep track of. But I wanted to give you a few tips and tools that can help make asthma as a disease state a little bit more manageable and make you feel like you have some control in your disease state. So we're going to talk about a few things today that you can take control of right now today to help manage your asthma symptoms. We're going to be talking about medications first. And first and foremost, the most important thing that you can do is make sure you are meeting with an asthma care provider and taking your medications as they are prescribed. And we'll talk a little bit more about those in detail. The next is the Asthma Journal, which is a great tool to incorporate into your day-to-day asthma care to help you get a good understanding of what your symptoms are, what your triggers are, because everybody's asthma experience is going to be different from person to person. And we need to be really aware of what our asthma experience is so that when our asthma provider asks us questions, we can answer those questions effectively. And then lastly, we'll talk about some lifestyle changes that can be implemented into your day-to-day routine that can help manage some of your asthma symptoms. So first and foremost, Your medications are really the most important part of managing your day-to-day symptoms. So let's talk about the different types of medications that could be prescribed in a little bit more detail. So Matthew talked in a little bit of background about that short-acting or rescue medication. And some people might refer to this as their emergency medication or their rescue inhaler. So this medication is for emergency situations. This is a therapy, the short-acting therapy or SABAs should only be used if you are feeling tightness in the chest or wheezing, you're not able to get good airflow in. So these are emergency situations. And like Matthew said, with those rule of twos, if you are using your short-acting inhaler or your rescue inhaler more than 2 times per week, or refilling that inhaler more than 2 times per year, that is putting you at risk for future exacerbations. This medicine is not meant to be used on a day-to-day basis. That's where those long-acting controllers come in, that next step down on our slide. You might also hear these referred to as maintenance inhalers. So those maintenance inhalers, it's a really good name to call them because they are what you're going to take every day in order to maintain your symptoms. And those day-to-day medications, those are inhalers. So Matthew talked about a couple of different ones. Inhaled corticosteroids are very common. Also, long-acting beta agonists or LABAs are very common as maintenance medications. But the most important thing for you to do as a patient is if you are prescribed one of these maintenance medications, you take it every single day as prescribed. And if you do miss a dose, have a plan developed with your provider on what you need to do if you miss a dose. So if you miss it and remember it an hour later, can you take your inhaler then? If you miss it and remember it a day later, what do you do in that situation? And we'll talk a little bit more about how to develop a plan like that toward the end of our presentation. Going counterclockwise around the circle, the next therapy that we'll talk about is those oral steroids. So oral steroids are commonly given, again, in that rescue or emergency type situation, where if you are feeling like you have an asthma attack and you go to an emergency room or an urgent care, a lot of times a physician will prescribe oral steroids for you to take. And steroids are great. They help us feel better when we're having an exacerbation. But like Matthew said, when you're taking them more than just once a year or taking them frequently, that's when oral steroids can be very dangerous because that puts you at risk of having more exacerbations in the future. That means that your maintenance inhalers may not be the right dose or may not be the right therapy for you, and there needs to be some changes to your maintenance therapy. So it's really important if you ever go to an urgent care or an emergency room and you do get prescribed steroids, to send a quick message to your asthma care provider and let them know that, hey, I'm having an asthma exacerbation. I was prescribed oral steroids, and you can even tell them the name of the steroid and the instructions that you were given in that urgent care setting. And that helps your asthma provider know, okay, my patient had an exacerbation and I need to make some adjustments to their maintenance medications, their day-to-day medications, to help prevent them from having to take these oral steroids again in the future. Continuing around our circle, the biologic medications. So not everybody is going to be prescribed a biologic medication, but like as Matthew said, in talking about inflammation or that swelling in the airway, some people's immune systems are just overactive in their airways, and that leads to those asthma symptoms. And the biologic medicines, they help to target the specific cells in the immune system that might be overactive. So like I mentioned, not everybody's going to get prescribed one of these biologic medications, but if your maintenance medications are not helping you manage your symptoms on a day-to-day basis, your asthma care provider may talk to you about one of these biologic medications. And then lastly, allergy medicines. So we talked a little bit about triggers and triggers that can activate your immune system very commonly are allergens. And so if you do have a specific allergy, There are certain allergy medications that can help manage those symptoms, but again, that's going to be different from patient to patient. Not every person is going to need the biologic or the allergy medications. Now moving on to that asthma journal. So I used an asthma journal early in my asthma journey, and it was extremely helpful, and it's very easy to do. So I wanted to talk a little bit about this today. If you scan the QR code that's at the bottom of the slide, it will take you to our website, and there are free asthma journals for you to use, but there's lots of different versions. There are apps that you can download for your phone. What I like to do is I write them on a physical calendar. But the type of information that we're trying to track from day to day is primarily how you're feeling from day to day. So if your doctor told you to use a peak flow meter, which is a little device that you blow into at home and track the amount of air that you blow into, that can be measured from day to day. Also, if you have an exacerbation or have a change in your symptoms, those are things that you'll want to write down, and any triggers that you were exposed to when those symptoms happen. So how I used my asthma journal is I noticed one day I wasn't feeling great. I wrote down what my symptoms were, and then I looked at the air quality, and we'll tell you how to do that in just a couple of slides. But the reason I wasn't feeling good is because, exactly as Matthew said, the wildfire smoke blowing down from Canada was really, really bad that day, and it made me feel really terrible. I was having a hard time breathing. So writing down what those triggers are will be really helpful for your asthma care provider to figure out, okay, what is a plan that we can do if you are ever exposed to this particular trigger again. If you don't know what your trigger is, then you won't have a plan developed. And on average, asthma patients have about 8 triggers that they're susceptible to. So there's a lot of different potential opportunities that you could get exposed to that might make your symptoms worse. Next would be anytime you use your rescue inhaler, write that down and write what symptoms you were experiencing when you use that rescue inhaler. Same thing with those oral steroids. Those should be only used in an exacerbation setting. And so we need to write down what was going on when we took those oral steroids, and any disruptions to your day-to-day activity, like waking up in the middle of the night due to your asthma symptoms or missing work or school. And then lastly, talking about different things that you can incorporate into your lifestyle to help you reduce your asthma triggers. So like I mentioned, those asthma triggers are going to be different for everybody. So incorporating all of these is not necessary for every patient. But once you figure out with your asthma journal what your triggers are, you can take some steps to help mitigate some of those exposure to asthma triggers. And we'll break it down into 2 categories. First, around things you can do around your house, and then any healthy choices. So things that you can do within your own home that are pretty easy to implement. First and foremost is just keeping a clean house. So making sure you're vacuuming, and anytime you vacuum, empty the dustbin outside so you're not recirculating all that dust that can potentially cause an asthma exacerbation. Washing all of your sheets and blankets, any bedding, and using hypoallergenic covers on your bedding is going to help reduce that dust exposure. Also using things like air purifiers, making sure your windows and doors are well sealed. One thing that's on here that might make people a little bit nervous is sometimes people can be very sensitive to pet dander, so your dogs and cats. That doesn't mean that you can't have a dog or a cat. It just means we want to keep them out of the bedroom primarily. And that bedroom, the reason we want to keep them out of there is your sheets and blankets really pick up a lot of that pet dander. And it can, anytime you lay in your bed, it can irritate your airways. So as long as we're keeping those pets out of the bedroom, we can still have pets around the house unless you have a very, very severe allergy. So talk to your asthma care provider about what you need to do if you do have one of those animal dander triggers. And then in terms of lifestyle changes, these are, again, very easy to implement into your day-to-day practice, but they are also helpful for a wide variety of disease states, not just for asthma. So we want to make sure that we're managing stress, we're avoiding any sort of tobacco smoke, maintaining a healthy weight, eating well, exercising daily, and most importantly, we did talk about adhering to any medications that you are prescribed. And I wanted to talk about smoke in particular because, as we all know, smoking is a very common trigger for patients with asthma. So whether or not you smoke or you're in a house with smoke, these can be really dangerous for patients with asthma. So what happens to a patient who smokes and has asthma? They are more likely to have exacerbations. They can have increased mucus in their airways, so making those airways much narrower, making it harder to breathe. And you can have an increased risk of lung cancer. So if you are a smoker and you have asthma, please, please, please talk to your asthma care provider about the tools needed to try and quit smoking. But not just ourselves as smokers, other people, if you are a maybe caregiver for a child, we don't want that secondhand smoke around any asthma patient. So a common scenario that we'll see out in the community is a child with asthma, maybe the parent doesn't smoke, but one of their other caregivers, like a grandparent or an aunt and uncle, does smoke. Speaking to that caregiver about staying away from the patient with asthma as much as possible. Try and, if you can't quit smoking, smoke outside. Don't smoke in the car with the child with asthma. Just try and keep that smoke away from the asthma patient as much as possible. And something that's not talked about very commonly is third-hand smoke. So any sort of cigarette residue will end up on soft surfaces in homes, so on clothing, on furniture, on bedding, and that can also trigger asthma exacerbations. So any sort of smoke exposure can be dangerous for somebody with asthma. And vaping is another area where people have thought, oh, well, smoking is so bad, why don't I just switch to vaping? Without realizing how dangerous vaping can be, again, with anyone with asthma. So in terms of vaping, there's much higher levels of nicotine in your e-cigarettes compared to a traditional cigarette. So they are not safer by any means. Anything you breathe into your lungs can cause lung damage. Additionally, not many people realize that vape smoke can cause secondhand smoke as well. So we're very aware of secondhand smoke from cigarettes, but you can have secondhand experiences from vapes as well. And this can cause traditional asthma flare-ups in patients with asthma. So if you smoke or if you vape, please do your best to try and quit smoking or vaping and talk to your healthcare provider about how to do that. And then talking about the outdoor air quality, so we mentioned wildfire smoke. There's a really easy way to check for your outdoor air quality. You can go to airnow.gov, or if you have some sort of home device like an Alexa or a Google Home, you can just ask them from day to day. It comes on your local weather reports as well, what the air quality is. And we are particularly concerned about anything from this orange category down. All of those are considered unsafe for sensitive groups, which includes people with asthma. So if your air quality is poor, follow that advice got outlined here. If you need to be outside, try and wear an N95 or KN95 mask. Try to limit any outdoor exertion. So if you want to go for a run, don't run outside, run on the treadmill inside. So there are steps that you can take to try and mitigate the triggers that you're exposed to. And then the last major area I wanted to talk about is other diseases. So there are a lot of other diseases that can impact your asthma control. Very common ones are other respiratory conditions like respiratory infections and COPD, but there are some less common things that we might not think about. So certain skin conditions like eczema and food allergies might be unexpected, but those are also commonly overlap with asthma. Additionally, what did not end up on this slide, certain mental health disorders like anxiety and depression will also impact your ability to control your asthma. So bottom line of this slide is if you have another disease state and asthma, make sure you are actively treating that other disease state because that can impact your asthma control. And then this is just a quick summary slide, but I'm going to pass it back over to Matthew here so he can close us out on time. Oh, I think you're...
Thank you so much, Emily. Appreciate it. So yeah, pulling this all together, putting the plan in place with the asthma action plan to really help you, help those loved ones, if you're a caregiver, really do the best that we can to control your asthma both now and in the future as well. So the asthma action plan that Emily had previously touched on, really the ultimate goal is to prevent future attacks. Now, it's not bulletproof, right? Seasons change, and as a result, triggers can change if those are the triggers for you, perhaps. But working to identify those with the help of the asthma journal that Emily had previously called out under the asthma action plan can really, again, work toward preventing asthma attacks as much as we can. So recognizing too that the asthma action plan is unique to yourself. And if you know somebody else with asthma, their asthma action plan may look completely different. And that's okay. We want them to be tailor-made for the individual. But things that should be called out in each asthma action plan include how to manage your asthma daily. So this touches back on the maintenance regimens that Emily talked about, those controllers that are taken daily, sometimes twice daily to really help control symptoms and control inflammation as well. Importantly, what to do when your symptoms get worse. So oftentimes you might see things outlined in kind of a red light, yellow light, green light type of scenario. So how to manage at home and when you should call a doctor, how to adjust medications as needed, including those quick reliever medications or rescue medications, what to do when you exercise or get sick, because it is still important that you take your medications to keep that inflammation under control and at bay. And then importantly, who to contact in case of an emergency. So not only your provider and care team, but perhaps like a loved one as well that may be integral to your care. So working with you're good. You're okay. So working with your healthcare professional to work on developing this asthma action plan and importantly, checking it and updating it. So it's not going to be stale, it's going to be dynamic, it's going to evolve, but bring it with you, whether it's electronic or paper version, should be brought with you to your provider visits. So this touches on that kind of those different zones, if you will, for an asthma action plan. Again, may look different for you, but the green zone is where we want everybody to be. We're doing well. This is a good trajectory to be on. No asthma symptoms. We're going to continue taking our long-term controller medications, and then avoiding triggers as best we can, right? But what can happen is seasons change, things are out of your control. Maybe we shift toward the yellow zone. So our goal here is to get back to the green zone, but here in this zone, really you should work on slowing down, following the steps to keep asthma from getting worse, and keep taking your green zone medications, those maintenance medications, and any additional prescribed quick relief medications. And here, oftentimes, a good rule of thumb is that if you're not feeling better, you're getting worse, or in the yellow zone for more than a day, follow instructions in the red zone, and then importantly, call your healthcare provider. And then finally, the red zone, this is a call to action. So this means that you're experiencing that asthma attack or severe asthma symptoms or a flare-up. So this is really, we need to seek immediate help if the symptoms are getting worse and medicine's not helping. This is where we're going to be taking our quick relief medications immediately at the specified dose and frequency. So once every 4 to 6 hours as prescribed potentially. Excuse me, as prescribed, not potentially, but as prescribed. And also calling 911 if the following danger signs are present. So if there's any trouble walking, talking because of the shortness of breath, if there's blue in the lips or the fingernails, or if you still remain in this red zone after about 15 minutes. So we can progress, like, or regress, progress, get to the yellow zone is what I'm trying to say in a relatively quick time frame. But if we're not hitting that time frame within the 15 minutes, that would be one of the conditions where we should be calling 911. And multiple asthma action plans are out there. Lots of different organizations have them. So I think that the biggest thing is finding what works for you, whether it's electronic, it's a fillable PDF, if it's paper. The QR codes at the bottom are from different organizations that are stakeholders in the asthma space and more broadly the respiratory space. So feel free to scan those with your phone and find one that works well for you. And just want to conclude again by thanking all of you for your attendance. And again, Sandra, for the opportunity to collaborate with you in the Montefiore Naya community. We'll leave this slide up here for a moment. There's two QR codes on here. The first links out to our program's website, which again is LUMA. So that's the top QR code. And the bottom one is if you have any feedback for myself, Emily, for the content that we delivered in terms of what you didn't see and you want to see or what could be improved, feel free to submit that via the bottom QR code, and we'd welcome any questions.
Matt, there is a comment here. Do you do presentations for New York City school staff?
Yes, absolutely. So we do both our traditional programs, if you will, which is Emily and myself directly to patients, and then we also do a train the trainer, if you will, too. So taking a similar approach with the resources that we have, but just a different audience. So more than happy to, I'll copy paste this, and more than happy to connect and follow up.
Yeah, and I can connect you too.
Thank you.
Yeah,
That'd be
that'll
great.
be fine. Well, I don't see any other questions here, and I know that I always ask a lot of questions, but I feel that you guys explain everything so well, and that it's hard to really ask questions because you cover it all. Only one question that I always have. Does asthma manifest differently between children and adults?
Yeah, thoughtful question, and welcome Emily's thoughts here because I will say she's more the resident expert than myself, especially in the children's space, given her clinical background. But I'll take a quick stab at it and then hand it over to the resident expert. But the answer is yes, I would say. So in terms of presentation and types of asthma, to kind of just take a step back, generally speaking, when asthma presents in children, it's going to be more of an allergic type picture of asthma. That's not to say adults can't have allergic asthma, they definitely can, but generally that tends to be the most common type of asthma in the younger patient population. Whereas when we think about older adults, late onset asthma, sometimes we call it, it tends to be less of an allergic component and could be the another flavor of asthma that we've talked about called eosinophilic asthma. So again, that touching back on the different blood testing that we can do, or kind of in this catch-all that we sometimes say, which is a non-type 2 asthma. So that's like where we know it's not allergic, we know it's not eosinophilic, so we bucket it in this kind of catch-all bucket, which can be challenging to treat too, with our best therapies. As far as symptom presentation, obviously everybody's experience is going to be unique. Between some patients experiencing the wheezing, the shortness of breath, the chest tightness. But Emily, anything else to add or kind of expand upon?
Yeah, you did a great job covering the different types of asthma that a patient can experience throughout their lifetime. So oftentimes what we see happen, and just as a little bit of background, I was a pediatric clinical pharmacist, so I worked in the ICU when children would have asthma exacerbations that led them to being in the hospital. So very common for children in particular to wind up in the emergency room with an exacerbation and even be hospitalized. That you don't see that as commonly in adult patients, most commonly because by the time you're an adult, you are on a strong maintenance regimen. That as long as you are maintaining that inhaler every day, you are less likely to have those exacerbations. But children, as they are figuring out what type of asthma they have over time, they may have more exacerbations and more severe exacerbations that land them in the hospital. So it can be a very scary time for caregivers who are caring for these young children. Um, in terms of as patients grow, sometimes symptoms get a little bit less severe as children get older, but that doesn't necessarily mean they quote unquote outgrow their asthma. And so we want to make sure that we're keeping in touch with our asthma care providers as we get older, and modifying any therapies to fit those inflammation changes that Matthew mentioned over time.
Mhm. Well, thank you for that, because what you just said is very valuable, I think. I always thought, what people say, like you grow out of asthma, and you hear a lot of people saying the same thing. It's like, oh, I grew out of it.
Mhm.
But okay, so it's still there, so we gotta be careful.
Yep. And the only way to continue to maintain throughout your entire lifetime is to keep in touch with your asthma care provider. So just because you're feeling good doesn't necessarily mean you should stop seeing your asthma care provider.
Or not having your medications
Or
happen.
stop taking your
If you
medications.
have,
Yes.
God forbid, an attack, and now you don't have anything because you thought you grew out of it.
Yes, exactly. That's a fantastic point, Sandra.
Oh my God. You just saved, I don't know how many lives, because think about it, like how many people, how many adults walk around without having their asthma medication?
Yep,
Just
Totally.
have your asthma medication with you. That's it.
absolutely. Yes.
Okay. Well, thank you so much. Very powerful as always. All your presentations. I'm gonna connect you so
Thank
that
you.
hopefully you can be doing many more of these presentations. And you see, you're getting lots of hearts and hands. Like clapping. So, and thank you, of course, to our attendees and for your questions and for being here and for supporting community chats and all of our speakers. I will see you next week. Oh, before I forget, Diabetes Month is in November. So we're going to have a shift next month, and we're going to have all community chats solely dedicated to diabetes. It's going to be a 3-part series. We're going to be talking about the secret, oh my God, what was the title again? The secret factors that affect your blood sugars beyond the story of food. So please join us starting next month to learn more about diabetes and how to control it. That's all. Thank you so much, everyone. Take care.
Thank
Thank you,
you.
everyone.